Hey, welcome back. This is Dr. Linville. You guys did very well with your practicals. We're very proud of you. And now we're back and on track trying to look at some of the surgical procedures that are done with the elbow. So the first of two group presentations, the first one will be on Tommy John surgery, otherwise known as ulnar collateral ligament repair or reconstruction. And we'll get into the differences of what those two terms mean, as well as the different surgical procedures. So, the history, you'll notice these two gentlemen on the right. The gentleman on the top is Tommy John. He was a baseball player. And the person on the bottom right, he's an orthopedic surgeon in Los Angeles, and that is Dr. Job. So, for history here, in the middle of an excellent 1974 season, Tommy John permanently damaged the ulnar collateral ligament in his pitching arm, leading to a revolutionary surgical operation. This operation, now known as Tommy John surgery, replaced the ligament in the elbow of his pitching arm with a tendon from his right forearm. So extra credit if you guys can figure out which tendon in his forearm they used. The surgery was performed by Dr. Frank Job, and it seemed unlikely that Tommy John would ever be able to pitch again, as he spent the entire 1975 season in recovery after the surgery. Fortunately, he did return to the Dodgers in 1976. He posted a 10-10 record and this was considered a miraculous recovery. But not only that, he went on to pitch for 13 more years, winning 164 games after his surgery, 40 more than before, and one fewer than all-time great Sandy Koufax won in his entire career, who was another left-handed Dodgers pitcher, by the way. So Tommy John spent 1988 and 1989 as the oldest player in the major leagues, which matched Deacon McGuire's record for most seasons played in MLB career with 26 seasons played, which was then later broken by pitcher Nolan Ryan. So you can see 1974, Tommy John tore his UCL, and then with this procedure that no one had ever thought of before, Dr. Frank Job was able to reconstruct his ulnar collateral ligament, which allowed him to play 15 more seasons following his initial injury. So pretty miraculous stuff. So this got people thinking that tearing your UCL was not a death sentence, so to speak, for throwing athletes after this point. If you guys are interested to know more about the relationship, there's a really good ESPN 30 for 30. It's considered a 30 for 30 short, which means it's about 10 minutes long. You can find it on YouTube. I've given you guys a link here. I think you have to pay for this one, maybe like $2 or something. But it's well worth the watch if you guys are interested in baseball. You could also probably find it, on the black market YouTube somewhere. So it's called Tommy and Frank. Really cool story. Unfortunately, 2014, Frank Job did pass away, but he was inducted into the National Baseball Hall of Fame for his contributions in, helping with Tommy John surgery and UCL reconstruction. He now is kind of memorialized by the Curlin Job Institute, which is one of the nationally renowned medical centers for overhead athletes, which is located in LA. So if we think about the UCL, we're going to look at anatomic and etiologic factors. Just some background information here, and this is also going to be in your differential diagnosis lectures that I've given you, but the UCL background information: injury to the major stabilizer of the medial elbow. The UCL is comprised of three bands: the anterior, posterior, and transverse portions. We call these the bundles. The bony anatomy provides primary stability at less than 20 degrees of elbow flexion and also greater than 120 degrees of elbow flexion. So there's a big arcing range, about 100 degrees, that is not stable by bony anatomy alone. So soft tissue restraints provide the primary static and dynamic stability from 20 to 120 degrees of flexion, and this is also the arc of motion where overhead throwing occurs. The mechanism of injury for a UCL tear is repetitive valgus overload, i.e. throwing. You could also have a trauma causing an extreme valgus stress, such as rock climbing and falling off the side of the rock and landing on your elbow. We'll touch on that later. Your patient, prior to any sort of surgery or anything like that, will report medial elbow pain. They'll have pain during throwing. They may have pain, laxity, and gapping with valgus stress test or special test. They may even report a history of a pop or numbness and tingling into their hand. And maybe you guys can try to figure out which nerve distribution might be the most common that they complain of paresthesias in. As we continue on here, the UCL originates from a 9.6 millimeter wide area of the raised surface of the antero-inferior aspect of the medial epicondyle. It's a mouthful. This occupies 67% of the width of the epicondyle, and the two bands function in a reciprocal fashion, with the posterior band tight in higher degrees of flexion and the anterior band tight in lower degrees of flexion. If you think about the throwing motion, when you go from the cocking phase to full extension and ball release, the time that the elbow is going to be stressed the most in a valgus force is probably going to be in what we would consider lower degrees of flexion. So the anterior band would be more taut in this position. Diagnosis and evaluation. You're going to look for reproduction of symptoms or pain with any of the following, and we're going to go over special tests in class, of course, but here's a brief overview. If they have palpation, produces pain when you palpate the sublime tubercle or in the mid-substance UCL, you should be suspect of a UCL injury. If you don't know what the sublime tubercle is, I'm sure Dr. Kraut might have mentioned it in passing, but I want you guys to look up the sublime tubercle. It's an important structure on the ulna. The valgus stress test, you guys know these probably from, or actually you probably don't know yet, from the knee, but this is where we stress the the joint into a valgus or varus overload position. We test this at both 0 degrees and 20 to 30 degrees of flexion. We'll go over a special test called the milking maneuver, and then we'll also go over one which is described by O'Driscoll here, and I've also opened up an article for you guys to read on this called valgus extension overload test, or some people call it the moving valgus stress test, where essentially you perform a valgus stress test while simultaneously extending the elbow, kind of recreating the ball release stress that they might be feeling. Of the three ligaments making up the UCL complex, only the anterior bundle provides significant restraint to valgus force of the elbow from 30 to 120 degrees, and that's in a moving arc of motion. So what happens to someone you suspect might have a UCL injury? Well, you're going to try to treat them with conservative measures first, but if that doesn't work, we'll go over some conservative measures, but if that doesn't work, they might get MRI imaging. So there is MRI, this is an MRA, which is a magnetic resonance arthrogram, where they inject dye into the joint and then are able to see the dye and where it goes based on pathology or joint space and that sort of thing. So you can see the elbow joint here. And if I click my mouse right over this area here, if you were to flip this 90 degrees to the left, this would look like the letter T. And this is considered a T sign coined by Dr. James Andrews, which is indicative of a UCL tear. This is the medial elbow here. And as far as conservative treatments goes, they have been effective when low-grade partial tears are confirmed by arthrography, but when high-grade or complete injury are apparent, the probability of return to sports is low. Reddig et al. Reported on non-operative treatment of throwing athletes, and they found that only 42% return to previous levels of competition at an average of 24.5 weeks. So 4 out of 10 people with conservative treatment return to sport after 6 months. It's not very good. Treatments include rest, anti-inflammatory meds, possible bracing or splinting of the elbow, and physical therapy. If they do fail conservative treatment, they usually look at surgical options. And right now, these days, they just kind of go right to surgery because of some of these studies that have showed conservative treatment is not very good. UCL reconstruction is the main one. There's also now a really, really strong push for UCL repair, which is trying to spare as much native ligament as we can and repairing that back down to the bones rather than removing and reconstructing the entire ligament. There are several different reconstruction techniques. I'll have you guys read the Jeff Dugas article, really one of the pioneers over the last 10 years. He is, I think, a James Andrews camp guy. So he's well renowned now in the world of UCL repairs and reconstructions. There's a lot of presentations on this stuff. So conservative treatment, if we go back to that Reddick article, it was a study of 31 athletes who were managed with 3 months of rest, followed by 3 months of strengthening, rehab, and return to throwing. There's a 42% return to sport rate. It did not look if they returned to their previous level of competition. Just ask if they got back to some sort of sport. There's also a technique that's gained a lot of popularity in the last 5 years, is platelet-rich plasma, or PRP. You've probably heard of this. It's still new and controversial in this area as another potential non-operative treatment option for the patients with UCL tears. And maybe we'll get into a group presentation of this one day, not just in the UCL, but it'd be a good one for you guys to do a like extra credit research into. It's PRP interventions. And what you're looking at on the right is a picture of a needle they're injecting PRP into the medial elbow. Try to help with healing. So now let's look at the surgical procedure. Check out this guy's body mechanics. No wonder people tear their elbows. I wonder what his shoulder's doing. Cervical spine. And it's crazy what we demand of our bodies, and also crazy what it can give us. So if you tell me that he doesn't have a labral tear, then I'll tell you you're out of your mind. Surgical candidates for UCL reconstruction. Here are the indications. If they have an acute rupture and a high-level thrower, if they have symptomatic and chronic instability, if they have insufficient UCL tissue following debridement of calcifications, which sometimes they'll go in and do, tissue debridement, scar tissue removal, or heterotrophic bone removal. Recurrent pain with throwing after appropriate rest and rehab, aka conservative treatment. And so those are some surgical considerations. Now here we're going to go over the Jobe technique. Now this is the one that he first did back in 1975, 74, and there are several concerns with it. There's a high complication rate. There's an odd surgical approach that's been refined over the decades, now 40 years of doing this type of surgery. And there's also different graft fixations. So Jobe's original approach involved detachment of the flexor pronator mass origin from the medial epicondyle. He then did a submuscular ulnar nerve transposition with subsequent repair of the muscle tendon origin. So he basically flipped down the flexor pronator mass, tucked the ulnar nerve under it, and then while the flexor pronator mass was retracted, reconstructed the ligament, and then following, tucked the ulnar nerve under there, and then repaired the muscle back down to the bone. This resulted in a high rate of ulnar neuropathy and morbidity associated with transection and repair of the flexor pronator mass. The high complication rate of this procedure led to the development of many modifications. One early modification of the Jobe technique was clinically reported by Thompson et al. on 83 patients. They used a muscle splitting approach described by Smith with the original figure of 8 configuration and no ulnar nerve transposition. Of those 83 patients, 33 patients were throwers, and 82% of those returned to their previous level of play or higher. The overall complication rate was decreased to 10%, with only 4 of those 33 having transient ulnar nerve symptoms. Here's the original Job technique, and this is not looking at his flexor pronator mass resection and repair. This is looking at the bony and ligamentous reconstruction here. Ulnar collateral ligament graft reconstruction you can see here, and that is a tendon. Remember, I'll let you guys figure out which tendon they used. It's considered an autograft, right? Auto meaning from, someone's own tissue. You can also have allografts or xenografts. I'll explain what those are later. But you can see where they've drilled holes into both the ulna and the humerus, and how they've kind of configured this as a figure of 8 technique to reconstruct and reinforce the medial elbow. Now the ASM modification, 1995, James Andrews. ASM stands for Andrews Sports Medicine Institute, by the way. Modified the original approach by sparing the flexor pronator mass and elevating the flexor pronator muscle overlying the UCL, exposing the sublime tubercle and the ligament. So basically this would be more of a muscle splitting technique rather than a muscle resecting technique. He did use subcutaneous ulnar nerve transposition and then kind of reconstructed that with a fascial sling. We just took some fascia and created a sling for the ulnar nerve to sit in. The results of these patients was presented by a study from Kane et al., and it looked at, he's part of the ASMI group, looked at nearly 1,300 throwing athletes between 1988 and 2006. They had patient follow-up of 79% who were at least 2 years post-UCL reconstruction. 83% of the athletes returned to their pre-injury level of play or higher. Average time from surgery to initiate throwing was 4.4 months, and the average time to full competition was 11.6 months. Among the baseball players, return to the same level of play occurred in 75% of Major League, 73% of Minor League, 87% collegiate, and 83% of high school. So these are much better results than other studies thus far. Complications did occur in about 20% of patients. The most common complication was transient ulnar nerve symptoms, which again, this has been kind of the big complication with any of these surgeries is ulnar nerve issues. About 16% of patients had these symptoms, which resolved around 3 months. Here's the modified Job or the ASMI technique. It's very similar, you can see in style to the Job technique, however, with a much different muscle splitting and ulnar nerve techniques within the operation. There's also something called the docking technique. Now all these, I'll just put this out here now. There's several different ways you can skin a cat. Same thing with the UCL reconstruction. Now the cool thing is that with each subsequent technique, they're starting to really refine what might be the best general technique for everyone. Now, when we get into what the repair is, the UCL repair, we'll talk about, just as we do with the rotator cuff, why tissue quality is so important. Also have to take into account different things like age, gender, what they want to get back to, those sorts of levels of concern. So docking technique, look, I don't expect you guys to memorize every single one of these. I just want you guys to know that there are several different ones. So we might skim through some of these. So docking technique utilizes the muscle splitting approach, but reconstructs the UCL by placing sutures into the end of each limb of the graft And after shuttling the graft through the traditional ulnar bone tunnels, each limb is then quote-unquote docked into the medial epicondyle by pulling and securing the suture limbs through small exiting holes in the proximal epicondyle. There's no obligatory ulnar nerve transposition. This technique was developed over the concern for the risk of medial epicondyle fracture with traditional figure of 8 bone tunnels. In a systematic review in 2008 looked at and showed improved outcomes and decreased the complication rate if compared with the original Job technique. 92% of patients with this returned to pre-injury levels. And a big difference here, if you go back to the other pictures, which I'll let you guys do, the docking technique, they still drill holes, of course, into the bone, but I think there's less bone damage here. And as you can see, there's no figure of 8, tension used here. Those are just suture wires, which bone will just cover that, after they've drilled those holes, and will create a nice, secure reconstruction. Now we also have an interference screw technique, and this is used in several different surgical procedures, including rotator cuff repair. Well, they'll use a screw, and they'll kind of suture, they'll use some like fiber wire and things like that to connect the end of the ligament to an anchor, which then they'll, insert and anchor into the bone, which creates a nice sturdy repair reconstruction as well. So the interference screw technique was first introduced using interference screw technology to reconstruct the UCL. It was described first by Ahmed in 2003. With a single tunnel in both the epicondyle and the sublime tubercle, they attempted to isometrically reconstruct the anterior bundle of the UCL. Moreover, using biocomposite screws for fixation, they showed promising biomechanical results when compared with the native ligament. So interference screws, here's a artist rendition. You can see the other bundles of the UCL there, and the one with the anterior bundle, they've kind of removed that or debrided it since it was torn, and then only used 2 bone tunnels here, which then they passed interference screws through. So much less bone damage, and pretty novel technique, right? Then you have the Dane Tommy John technique, which is a hybrid of 2 fixation strategies described by David Alchek, D.A., and Neil L. Atrache, giving you the term Dane for UCL reconstruction. So I think Neil L. Atrache maybe Alchek too, just gave a presentation out here, or is going to, in Phoenix or Scottsdale on throwing injuries. And, Ed came up to me and told me about that conference that they'll be at. So if it hasn't happened already, you might want to talk to Ed about getting in and seeing it. I think there's a student discount, but these guys will be talking, at least Neil will be talking on throwing injuries. This technique was developed to improve tensioning and avoid complications with bone tunnels and ulnar nerve dissection by using a single tunnel with screw fixation distally and the docking method proximally. So this is using both the interference screw and the docking technique. Dines et al. Came out with a study looking at the results of this, and with 22 subjects, 86% returned to their previous level of play. 4 minor complications occur, with 3 requiring reoperation. So here's that idea. Proximally, you have the docking technique. Distally, you have the interference screw. Pretty cool how they're, using different techniques. So what is a reconstruction versus a repair? Well, reconstruction is using graft tissue to remake the ligament. That can be an autograft, an allograft, or a xenograft. So an autograft, like we mentioned before, is from your own body tissue. An allograft is from a cadaver. And a xenograft, I'm going to let you guys figure out what that is, extra credit, what a xenograft is. And by extra credit, I mean you don't really get points. It's just for your own knowledge because you're in grad school. A repair is fixing the original ligament. And they're doing this now with UCL surgeries using what they call internal bracing. And this was proposed by Dugas. Again, remember we talked, he's one of the pioneers of this update in technology and surgical approach over the last several years. It's typically used in the ankle for lateral ligament repairs. So they've taken ankle surgery techniques and now incorporating them into the medial elbow. Dugas looked at 40 patients, and 39 out of the 40 returned to the previous level of function at 5 to 6 months using this internal bracing ligament repair technique. The one that did not return to their previous level was a 23-year-old female rock climber, and she had preoperative ulnar nerve problems, and she never was able to return to rock climbing because her ulnar nerve problems persisted. Although, as he described it on exam, her elbow is very stable. So he feels that the actual surgical technique did its job orthopedically. So she might need some help with neurologic function, however. Here's the UCL repair. What they use is this white, basically collagen-coated fiber tape with sutures on the ends. And if you look closely at the picture at the bottom right, they do use a kind of an interference screw technique where they have anchors, which is the blue. They're anchored back down this scaffold, for lack of a better term, because what they're going to do is they place that right over the native ligament. They drill holes in the bone, use interference screws to lock down that blue anchor, and then using the white collagen-coated fiber tape will repair the native ligament to these suture anchors. And what will happen over time is, we think because it's collagen-coated, and he's actually shown this he's had to go in and do a subsequent surgery in one of these guys. What happens is that your body's own collagen will kind of cover this up and reinforce and make your native ligament stronger. So this was proposed in 2017 at the Injuries in Baseball course, which is hosted by ASMI. If you guys are interested in learning more about the internal bracing technique, I can give you guys a video. There is a surgical video, as you see on the bottom, Jeff Dugas UCL repair. We're talking about with internal bracing. It seems to be the new and just the newest and hottest method in ulnar collateral ligament management. If you click on the top video, or you at least type that in, you'll get Dr. James Andrews, his thoughts on Tommy John. And if you want to see the docking technique, which I think is one of the most widely used techniques still, has very good results, and you can look at the video there. I'd encourage you to watch each, especially the docking technique versus the UCL repair. They're very different. So the physical therapy guidelines, we're going to let the group present on this. But I want you guys to go back through this if you can and write down any questions you might have. The elbow and throwing athletes is one of my big interests in the world of physical therapy. Presented at ACSM, not ACSM, but CSM on the elbow. And if any of you are interested in throwing athletes, then come talk to me. We'll talk about maybe what steps you need to do to get into more of that line of work. So thank you guys for your continued hard work this term. I know it's hard coming back after your practicals, but we're going to get back after this, and now you know what to expect, and you guys are just going to get better from here on out. So really good job. Thanks for your attention, and I'll see you guys in class.